Well, thank you to all of our surgeons for presenting for us today, and we've got a time for a few questions. Who gets to go first? Do I get to roll the dice? All right, this actually is a question for all of you. Do you treat all stages of lipedema, and do you have a BMI requirement? Dr. Gutowski, you're on the end. I'll let you go first.
No BMI cutoffs. I treat people who are symptomatic. If it's not symptomatic, but it's cosmetic, we treat them also.
I agree. I don't have a BMI cutoff, so I'll treat everyone. The staging might be a little different depending on BMI. For larger patients, they may need more procedures.
Yeah, everybody from stage 0 to stage 4, of course, and I'm glad to see people who are now starting to not pay attention to BMI as much, and so I just basically ignore the BMI. I think it's been a problem for years in terms of these patients getting stuck without moving ahead with their treatment plan.
Yeah, there's no, like everyone else, there's no BMI limit. You will treat the patients differently as they go up in weight too, and it'll be a more complex treatment process for a patient that's heavier, for example, too, and we would adjust as needed.
If you have lipedema, we treat it.
Now, I'm the outlier here, so I do have a BMI limit, so I won't do surgery on somewhere around between 55 and 60, so I will often I do address try and get weight loss, sometimes refer to bariatric people, and sometimes if it's just lipedema, then I will often refer to surgeons that will do in hospital for them, so that they can more safely address that.
I agree. I don't have a BMI limit, but with the upper stages, sometimes that requires more careful surgical planning and thorough discussion.
And that's a nice lead into the next question is when is it safe and preferable to do surgery in the office versus doing it in a hospital stay?
Depends on someone's overall medical condition. It depends on how much you're taking out. I'd be careful in answering this question in 30 seconds when I think all of us tailor the procedure, the treatment to each patient specifically. So I'm not going to just give an answer like that. Every patient, some of my patients, I do their calves under local, and I'll do their trunk with anesthesia in the hospital. It just depends. You got to get evaluated. You got to talk to the surgeon, come up with an appropriate plan.
Does anyone have a differing opinion?
Different what?
Differing opinion than Dr. Gutowski?
I don't.
I can't remember what he said, but I mean, I can barely remember the question, honestly, at this point. Right? Almost happy hour. I personally don't like doing surgeries in hospitals. I actually find that you have much more control of the patient experience and control of many things in your own surgical center with your own team you work with over and over again. The complicated patients, of course, go through a much more extensive workup and stuff like that, but I prefer to operate in my own surgical center.
Okay. Unless someone else has another opinion, we'll continue on with the questions? Okay. So the next question is, since each individual will experience natural skin retraction at varying unknown levels, is it better to remove the diseased tissue first and readdress the possibility of skin removal after the skin settles in? Who would like to take that?
I think I just talked about what my preference is, so I won't rehash that. I think it varies patient to patient. I individualize it. It can be, in one patient, a good idea to remove the skin concurrent with liposuction, and in others to stage it. That's my opinion.
I want to say, I agree with Dr. Schwartz's talk. I'm actually glad that we got that question. I do things very similar to what he does. I break the body up into front and back. I do find that by treating the front first or the back first, that people heal a lot faster, there's less swelling. When I go circumferentially, because of how thorough we are, the swelling can last forever, and it really takes a longer time to heal. The second thing is I stage almost all of the skin excisions. Since we started doing the manual and taking out all the nodules, in fact, a lot of the arms and even some thighs don't need arm lifts or thigh lifts. And the honest thing is, if we can get away without doing those, because those are more complex procedures, harder to heal, I think it's better. So we talked about that as beginning as a team, and that's what I think is the best way to go, but I'm not discounting anybody else.
For us, I've tended to go much less towards immediate skin resections because I find with good therapy and the good compression applied right afterwards, you still get more retraction of that skin than I used to appreciate. And absolutely, there are big patients, and we will go right on the table and resect skin as necessary. And so Dr. Yudkowsky gave a wonderful talk on how those incisions need to go. Sometimes they're not going to be those cosmetic textbook perfect ones. They might go right across the front of the leg because that's where that patient's skin is. That patient's, if you try to resect it differently, you're going to have a very bad result. But overall, I've been impressed with how much more the skin does resect, even in lipedema patients. So we tend to leave it in general, but we are not afraid to take it in if we need to.
I feel the need to comment because I don't do skin excisions myself, so my experience with different plastic surgeons are that I agree a lot with what's been said, that we've gone in many different ways. We used to do it concomitantly, went back to doing it stage. Now we're doing most of it concomitantly, the brachioplasties, the thigh lifts. It depends on the patient. Abdominoplasties, currently we're tending to stage it.
So the next question, how effective long-term is liposuction in lipedema? If lipedema is a lifetime disorder, fat cells will continue forming and growing and long-term get us back to the initial situation. Do you agree with that? And is there any research looking at patients who had surgery 15, 20 years prior?
Yeah, lipedema is a chronic disease. It's not, nothing we do is cure for it. You're removing some of the diseased tissue. And actually, there is a study, it's been ongoing out of Germany at 4, 8, and 12 years. They've followed a large group of patients. These are very hard studies to do. They just published 2 years ago their 12-year follow-up, which shows the areas that were treated continue to maintain improvement. Now, for each individual person, things may be different, but overall, the areas that are treated do tend to maintain the results and the improvement over time.
I'm just going to jump in if it's okay. I've had a lot of experience for over 25 years, so this is my experience with this way I answer this common question to a patient. It's a disease that still exists. It potentially can come back, but it rarely does in less than 1% of patients in my experience. Those patients tend to have very aggressive lipedema and are more of the swellers, are moving a lot of fluid out. And as long as most patients maintain proper preventive measures of diet and compression, it really rarely comes back.
Here with lipedema, with lipos or suctioning out the fat, you're controlling the symptoms, you're not curing the disease like we're finding here. So one thing that I found key is, I agree too that if you've got it out, it'll stay out, that fat's in the bucket and it won't come back unless that patient starts to gain weight back, is our one caveat. So if they go and gain 50 pounds, it's going to go somewhere, and since you haven't gotten every last lipedema fat cell, those are going to disproportionately swell up and put weight back in those. It's going to go somewhere, and so in that sense you can get it back, but otherwise it tends to stay off.
We thought of that question, and that's exactly why we started doing research, and we spend a lot of time and energy into this. Our study right now has been retrospective, which means we're studying all the previous patients. Everybody that has surgery from now going forward, they're prospective. So before you have surgery with us, you fill out all those questionnaires, and then we study those constantly. So in 15 to 20 years, I'll come back and give you all those results as well too. So.
I want to echo a couple of other comments, and they're very good. And it really, lipedema needs to be treated comprehensively. It needs to include, it's a disease that doesn't have a cure, so it has to, diet, compression, all these lifestyle changes have to be maintained to really maintain the benefits of the liposuction. Or as I like to call it, lipedema reduction surgery.
Let me just add something. I agree that I think in most patients who maintain a stable weight, that it doesn't recur, although it is chronic. And I agree with Dr. Granzow that if patients gain weight, they'll gain it more in areas that haven't been treated, but they may gain it in the area that was treated. So that can happen. We do have a lot of patients report, even when we treat all the potential areas, that their breasts have gotten larger. So there is that issue. As women age, the breasts become more fatty in composition from fibrous breast tissue, and a lot of women with lipedema report that their breasts enlarge afterwards. So that can be an issue also.
That's a lipedema breast dog.
It's almost happy hour. All right, so our final question is, what do you see when inexperienced surgeons are performing surgery on lipedema patients?
A lot of things, because a lot of the inexperienced surgeons can't do it in a hospital. They're not surgeons. You can do anything you want in your office. There's no law that says someone straight out of medical school without any training, can't open an office and do liposuction. They'll sell you the machines and you'll take a weekend course and you're certified or whatever. There's no certification for this. So you can create deformities that are very hard to fix. You can treat things the wrong way. The biggest thing that I see is the patient doesn't have a plan. If they see someone who has a comprehensive lipedema practice, they will make a roadmap for you and address all the issues in a systematic and logical fashion that limits the number of surgeries you need and the amount of money you have to spend. If you go to someone who doesn't know what they're doing, they're going to jump all over the place, and then you're going to go somewhere else to get it fixed, and you're not going to end up happy with it. Find someone experienced who's been doing a lot of this, who is accomplished, because lipedema is not just simple liposuction. It's much more complex than that.
I can go on and on in this area. It's understanding proper pre-care, the complicated patients, which ones need pre-compression. It's the proper post-care on these patients, like we talked a lot. It's about anticoagulation protocols. It's about understanding how lipedema presents and strategically how to approach it with a proper treatment plan. It's the intervals between surgery. And there's, of course, the technical proficiency, because it's a weird type of surgery. You got to really have experience doing it.
Dr. Michael Schwartz?
Yeah, I agree with what Dr. Gutowski just said. It's best to go to somebody who does a lot of lipedema surgery, who's trained in surgery, and is not just somebody from another area of expertise deciding to do liposuction. That's dangerous.
Yes.
Just because you're seeing a board, let's say you're seeing your insurance company says you have to go see a board-certified plastic surgeon. That doesn't mean they're skilled in doing this. I'm in Chicago, the third largest city in the US with 5 academic centers. They send those patients to me because they've learned, even though they do, at one of them, they're the world experts in lymphedema, those surgeons have learned it's not lipedema, it's different. And so when their insurance says you have to go, I'm not going to mention any names, but to this academic center, they just say, look, we're not skilled in this, you got to go see this guy. So just because someone is board certified and whatever, and lymphedema and lipedema sound a lot alike, find and tell the insurance company, no, I want someone who's actually done 100 cases of this, not that this is going to be their first case. I don't know if you guys feel the same.
Yeah.
Well spoken.
Actually, I'm glad Dr. Gutowski brought that up. So I want people to think about this slightly differently. We've spent so much time trying to publish and to try to get insurance companies to cover this. My concern, short-term and long-term, is that if you go to someone that was pushed upon you or whatever it's going to be, and you get the insurance company to cover your procedures, if it doesn't work and you need revisions, going back to them and saying, I need now more surgeries when they said it was experimental is going to be very, very, very hard. So just think about that also. And the more we do that, especially in the US, we're now getting to a point, over 90% of the people we take care of in our office are covered by insurance. Insurance companies are finally coming around to this. We don't want to see it go the other direction where there's complications and revisions and all these things, and they're going to start saying, well, you know what, we told you it's not going to work, so we're not going to pay for it anymore. So just be careful.
Well, one last thing I'd like to add is, as Dr. Gutowski said, it should be comprehensive, and there should be a plan, and you really, it has to be a minimum amount of surgeries as possible, and And I agree also comprehensively in terms of compression and lifestyle and all, to just the optimal results, as everybody, I hope on the stage would want.
Well, thank you all very much for sharing this evening.